Bismillah ar-Rahman ar-Rahim. Today we are going to discuss the abdominal examination, or the so-called examination of the abdominal system in general. To start with, as we did last time, we have to do the general examination first. Number one, you have to look at the patient carefully and try to talk to him. ايش اسمك؟ Bawal. And ask him about time, place, etc. in order to make sure that he is fully oriented. You know what time is it now? About?
Yes.
After Asr or after Maghrib? What time now?
Asr. Maybe Arba.
Maybe Arba, excellent. And place, of course, and person, because you know chronic liver disease in particular is famous of being associated with the so-called hepatic encephalopathy, a complicated, a famous complication. Hepatic encephalopathy present sometimes with disorientation to time, place, or person. And the general body build of the patient may give you an idea. Those people with chronic liver disease, advanced liver failure, you will observe that they are classically jaundiced. Even you can observe jaundice from some distance. And when they talk, you can smell so-called fetal hepaticus. While you take history from patient, you can smell him. Abdomen, of course, will be distended. Sometimes you may find local bulge here or there. But to speak about general examination, the mental condition of the patient, the orientation or disorientation, the color of the patient, whether he is deeply jaundiced or severely pale, and the smell. And then again you have the choice. You may start by the head and neck and then go down, or start by the hand and then head and neck and go limbs, whatever. So let us start by the hands. What are the important signs of the hand of a patient with, for example, chronic liver disease? Clubbing is an important sign. And as I said last time, the definition of clubbing is the loss of angle between the nail and nail bed. This angle here, between nail and nail bed. Sometimes it is only grade 1. That is only loss of angle with fluctuation. Or maybe more than that, grade 2 or even 3. The color of the nails also may be of importance, especially if the patient is bleeding. You may find nails are pale. Patient with chronic liver disease also may have anemia of chronic illness, so-called anemia of chronic illness. And then look at the palms of the hands. The palms of the hand may show the so-called palmar erythema. Palmar erythema, we mean that erythema which involves thenar, hypothenar eminence and the distal parts of the fingers, while the center or the middle part may not be that erythematous. Pulmonary edema, in case of a chronic liver disease, is due to accumulation of certain toxins. Some of them are vasodilators. And once you are talking about toxins, don't forget to check for flapping tremors. Do like this. So ask patient to open his fingers this way, make sure that the elbow is stretched, and then ask him to get his hand extended position, and a little push, not too much, like that. Then wait and see. Again. If there is flapping tremor, you will notice that the patient will start to do like this. Flapping tremors are coarse tremors, of course, and in the case of chronic liver disease, they indicate again toxin accumulation, and these toxins are supposed to be detoxified by the liver. Many times in deeply jaundiced patients, we may be able to observe the jaundice even in the skin. Skin color will help us out. And then look at the sites of the IV cannulation or blood samples, or the skin in general of the hand, especially at the IV, at the venous side, because those people are bleeders by definition. Once you introduce a needle in a vein or take a blood test from here or there, it may be followed by a big ecchymosis because of the defect of the coagulation factors. Or it may be spontaneous even in the skin, anywhere, upper or lower limbs, abdomen, chest, anywhere. Again, this is because of the defect which occurs at the factor itself, which is the liver, cannot synthesize the clotting or coagulation factors. Temperature of the hand, generally speaking, chronic liver disease patient may be warm, especially alcoholics, if the alcohol is a cause of the chronic liver disease. Pulse. Pulse volume is of importance to us because once they accumulate vasodilator substances, you observe that the pulse volume is high. And if you check the pulse and find that the pulse volume is high, then the next step is to ask patient to do like this and check for collapsing pulse. Collapsing pulse, as I said last time, is seen whenever there is marked difference between systolic and diastolic blood pressure, the so-called pulse pressure. So the pulse pressure will be high. And this condition, don't forget when you measure the blood pressure to record it very carefully, because you will find that the difference between systolic and diastolic blood pressure is really high, maybe 60 or above. Vital signs, of course, including temperature, pulse rate, comment on the pulse in the usual way, we all know about it, and then respiratory rate. Take this opportunity and check respiratory rate. What is common here in chronic liver disease, that you find the patient, most of them, not all, are hyperventilating or tachypneic. Pulse rate will be high. Respiratory rate. Any respiratory rate more than 18 is considered to be tachypnea. Now what is the cause of that? Because of ammonia. The ammonia effect on the respiratory center, and it has a stimulant effect, stimulating and increasing respiratory rate. The commonest acid-base disturbance in a patient with chronic liver disease is respiratory alkalosis, because of the stimulant effect of ammonia on the respiratory center. Those people are washing out carbon dioxide. And then you can look at the skin carefully. Some people, especially those with metabolic disorders, you'll find the skin with a characteristic color. It's called, it is dark color, bronzed color, as in those with hemochromatosis. So skin will have certain color, which is in between black and green, like this. And this is due to a deposition of hemosiderin. What is the relation? That hemochromatosis, as you know, can induce chronic liver disease by itself, and even it may proceed to the famous complication of hepatocellular carcinoma. So you have to be careful on commenting on the skin color. The hair distribution itself is of importance here. We know that the male has more hair than female, usually, especially in certain areas. Those people with chronic liver disease, because of high level of estrogen, may lose that hair. Estrogen is supposed to be detoxified by the liver, but in this case, patient may not be able to do this job, and hence there may be loss of hair from the masculine places. And since we talk about masculine areas, we have to look carefully at the beard and the mustache. Normal males should have beard and mustache. If a patient has chronic liver disease, this may fall down, again due to accumulation of estrogen or high level of estrogen. Ask patient to look up please, up there, and look for pallor, because, as I said, they may have anemia of chronic illness versus anemia due to bleeding or severe varices or whatever. And you ask patient to look up, and you look at the conjunctiva of the patient, and then look for jaundice down here, and examine the sclera. So we look for pallor in the conjunctiva, or look for jaundice in the sclera, in the upper part in particular. Jaundice is an important sign in a patient of chronic liver disease, and of course we know why. Some of them, especially those with advanced liver disease going on for a long time, you may get parotid enlargement. Of course you have to palpate the parotid on both sides, and you will examine that. It's usually symmetrical, and you palpate the parotid in front of the lobule of ear. It is a salivary gland, as we know. Sometimes it's tender. If it's tender, it means that it may be infected even. So parotid enlargement is a sign of chronic liver disease. Ask the patient and look for any evidence of epistaxis as a part of the bleeding problems which may occur in patients with chronic liver disease due to a defective coagulation profile. And as I said, always smell the patient. You'll be able to smell the fetal hepaticus. Get your tongue out. Yeah. I look at the tongue of a patient. Many of those patients with chronic liver disease, they have the so-called glazed tongue or smooth tongue. They may have absence of the papillae of the tongue. And ask the patient to draw his tongue out, yes, and look again for pallor and jaundice. So where to look for jaundice? You look for jaundice in the sclera, in the mucous membrane, especially under the tongue, in the palate. You look for jaundice if it is advanced and severe in the skin, even when the whole skin may take the characteristic yellow coloration. While you look for pallor in the nail bed, in the palm of the hands, in the conjunctiva where ask patient look up, and in the mucous membrane in the inside of the lips here, or inside the mouth. So you have to know where to look for the sign. So pallor, jaundice, bleeding, parotid gland enlargement, smell, and quickly try to palpate the lymph nodes. We explain this and how to examine for the cervical lymph nodes. However, in case of an abdominal problem in general, always try to palpate for so-called supraclavicular lymph nodes. This is just above the clavicle. This is the clavicle of the patient here. And then you palpate in the left side, left supraclavicular lymph nodes. If this lymph node or these lymph nodes are palpable, we call it Virchow glands. Virchow glands may indicate malignancy from the upper part of the gastrointestinal tract, especially of the stomach. Meanwhile, the other lymph nodes may be also of significance if patient, for example, is having a lymphoma involving the liver, spleen, and lymph nodes, or other malignancies of the blood. Now, palpation of the thyroid or locating the place of trachea may not be of that great importance in such situation. However, it's better to do these things quickly, as we explained before when we examine the respiratory system. However, as I said, it is not of a great significance in a patient with abdominal disease. What's more important here is to look carefully for any signs of hepatic failure. I mean in the upper part of the chest and in the neck, sometimes even in the face, in the upper arms, in the areas which are drained by the superior vena cava. You may find pink spots like this, and this we call spider nevi. And they are nothing but dilated arteriole, so they are easily collapsible. If you press on them even by your finger or by the head of the pin, they empty. Once you remove your finger, they fill again. These are called spider nevi. Spider nevi, as I said, is another feature of liver cell failure or chronic liver disease. The breast also is an important sign. That is the normal male breast. There is no swelling, and if you palpate, you don't feel any abnormality. What do I expect in a patient with a chronic liver disease? Sometimes you may get glandular tissue in this area, around the areola. In this area, around the areola. This glandular tissue, if it is there, is firm, sometimes mildly tender, we call it gynecomastia. Can chronic liver disease get gynecomastia? Of course, no. The answer is yes. And mind you to go and read about the differential diagnosis of gynecomastia. One of them is a chronic liver disease, again, because of accumulation of estrogen in the body of a patient like this. And then You may go and examine lower limbs. When you go to the lower limbs, check carefully for lower limb edema. Because as I said, this is a chronic liver disease. One of the important functions of the liver is the synthesis of albumin. Patients with chronic liver disease may develop hypoalbuminemia state. In hypoalbuminemia, you get lower limb edema, which should be bilateral, and sometimes, most of the time, symmetrical. Again, remind you with the fact that you press with the thumb on the chin of the tibia, that is the anterior surface of the tibia, with your thumb. Press firmly, not very strongly, and keep it for 15 to 20 seconds. And then you remove it. You can see the edema. I think it's clear in this patient. If you come close, you can see that in place of my finger there is pitting edema here. Pitting edema may be caused by a variety of reasons, but in a patient with chronic liver disease, we consider it as a sign of hypoalbuminemia. And then you compare with the other side. Again, with the thumb on the chin of the tibia, apply pressure for 15 to 20 seconds on the anterior surface of the tibia. And then after that, you remove your finger. Again, you can observe the edema. Some people, they try to grade the edema. They say, for example, grade 1 if the edema is around the ankle, grade 2 if the edema is in the leg up to the middle, grade 3 to the knee, and grade 4 anything above it. However, this is not of importance. Or you can just say there is edema around the ankle, there is edema up to the middle of the leg, there is edema up to the knee, there is edema extending over the knee. But the important thing here is to do the test in the proper way and comment as edema, which is pitting edema, unilateral or bilateral. And then you say up to what? Up to what level? This may be very important in patients with edema state in general. Other signs like ecchymosis or bruises, as we said in the upper limbs, you may find it also here in the legs, especially with mild trauma. You may get big area of ecchymosis or bruises indicating coagulation abnormality. Please don't forget to palpate for dorsalis pedis and other arterial pulsation, and we explained this in the previous time in details. And then you go to the abdomen proper. When you examine the abdomen, the patient should be exposed from the nipples till the actually, ideally speaking, should be from the nipple to the knee, but of course we cannot do this. It is sufficient to expose from the nipples to the symphysis pubis. And then start the examination by the so-called inspection. You stand at the foot of the bed. Make sure that your patient is well centralized, like this. And then look carefully at the abdomen and comment on symmetry, if it is symmetrical or not. In this patient, for example, I noticed that the left side, the left hypochondria is a little bulgy. So we'll say that the abdomen is not symmetrical, it's bulging a little on the left upper quadrant. And this is it. Nothing else can be done from the foot of the bed other than commenting on symmetry. And then you move to the right side of the patient, and always be on the right side of the patient whenever you examine any patient. And start to complete the inspection. What type of breathing is happening? This man is breathing mainly by the abdomen, so we call it abdominothoracic. And can we see any visible swellings or masses? In a patient like this, we can see that there is some swelling in the left hypochondrium and also another one in the right hypochondrium. So we'll say that there is swelling in both right and left hypochondria. We are going to describe it in details when we come to the patient. and any dilated veins will be of great importance. Now, dilated veins of the abdomen could be one of three possibilities. Either you'll get dilated veins on both sides of the abdomen, or only one side sometimes, and the direction of blood flow will be from below up, and I explained that before. If this is a vein here, this area, then we have to empty the vein by two fingers, like that, press strongly and empty. And then remove the lower finger. If you notice that the vein rapidly fills, when you remove your lower index finger, this indicates that the direction of blood flow is from below up. The other possibility is that when you remove the lower finger, the vein does not fill. Repeat the same technique and remove the upper one. Now the vein is filling. This means that direction of blood flow is from above to down. Which of them is significant? If the vein is filling from below up. In an abdominal case, if there are dilated veins which fill from below up, this means that this particular patient is probably having inferior vena cava obstruction. What is the other possibility? The other possibility, you may get veins around the umbilicus, and usually, not in every case, usually you get dilated tortuous veins coming out from the umbilicus and directed to the periphery. Picture like this, we call it caput medusa. Caput medusa does not indicate inferior vena cava obstruction, but they indicate the presence of portal hypertension. So please remember, because we are going now to count signs indicative of portal hypertension, maybe at the end. And then look carefully for any abnormal peristalsis, which may indicate some form of intestinal obstruction. Any pulsation, the liver itself may be pulsatile. To detect pulsation in the abdomen, always try to keep your eyes tangential to the surface of the abdomen, the upper surface of the abdomen, and ask patient to hold his breath. This will enable you to see epigastric pulsations in case of hyperdynamic circulation, which is very common in chronic liver disease. You may be able even to see pulsation of the liver in certain conditions. So, abnormal pulsations, dilated veins, and scars. Many patients have scars of previous surgery, especially those who have been exposed to splenectomy, for example. Then you will find a scar in the left hypochondrium. Tumor removal, scar anywhere. Previous laparoscopic maneuvers, then you get 3 or 4 scars, small ones. And every case you have to ask the patient, what is the cause of this scar, or what is the cause of that one? And take a good history from the patient, because this will save you a lot of troubles and save your time also. So, visible peristalsis, dilated veins, scars of previous operation or trauma, visible organs, visible pulsations, and of course, if there is abdominal sweat, abdominal distension, as the case in patients with ascites. Sometimes ascitic patients will have very clear abdominal swelling, generalized all over the abdomen. You should never forget to look at the pubic hair of the patient. This one has typical male distribution, which is triangular with the apex directed up towards umbilicus. It's going up like this. People who are having advanced chronic liver disease or the so-called liver cell failure may manifest absence of this masculine pattern or male pattern will be replaced by feminine pattern when you get the upper border of the pubic hair with a crescentic appearance. Of course, I'm speaking about male, not female, with chronic liver disease. So to summarize, when you inspect the abdomen of the patient, go to the foot of the bed and comment on any asymmetry, and then come to the right side and make your comment on the pattern of respiration, abdominal, thoracic, or thoraco-abdominal, any visible organs, any visible peristalsis, any clear scar here or there, and ask patient why. Any abnormal pulsations, maybe here or liver, and the distribution of the pubic hair. And don't ever forget to comment on dilated veins in the way which I mentioned. Dilated veins may be normal, sometimes very thin people, you get normally dilated veins either, or visible vein, let us say visible vein. But in that condition, in normal thin individual with visible vein, the direction of blood flow will not be from below up. Dilated veins in the abdominal wall with the direction of blood flow from below up indicates, in most of the cases, inferior vena cava obstruction, while veins around the umbilicus in that direction are called caput medusa, and they indicate portal hypertension. What else? Go now to palpation. Start by superficial palpation, then deep palpation, then organ palpation. Before starting superficial palpation, you have always to ask the patient, do you have any pain? No. Always start with this question. Ask the patient if he feels pain in the abdomen or not. Why is that? In order to avoid this area, or be careful when you palpate that area. We don't want to give a patient more troubles by pressing strongly on a tender area. If patients say no pain here or there, then you can start superficial palpation and very carefully start from the right iliac fossa. Once you start superficial palpation, always keep your eye on the face of the patient, because if he feels pain, it will be clear on his facial expression. So don't remove your eyes from the face of the patient while you are performing superficial palpation. You start from the right iliac fossa, you end by the right iliac fossa, and then you go to the middle. So it will be this way. Keep your eyes on the face of the patient, like that, gently. This should be gentle palpation in this way. Always your eye on the face of the patient. And then once you reach this point, you go to the middle. Keep your eye on the face of the patient. This is not deep palpation, so don't press strongly. We will press strongly, yes. There is no contraindication, of course, during deep palpation. When you do deep palpation, you repeat the same, but deeper. The aim of superficial palpation is to check for tenderness and rigidity. Tenderness and rigidity. So keep your eye on the face of the patient, feel for rigidity. Once you finish superficial palpation, you move to deep palpation. Deep palpation will be deeper, a little deeper. The aim of deep palpation now is to feel for any masses in any place, not only liver and spleen. Maybe epigastric, indicating gastric tumor. Maybe colonic, in patient with colonic CA or chronic masses. Maybe suprapubic, a patient with bladder tumors or whatever. Maybe deep masses in the muscles, like benign tumors of the muscle tissue or just under the skin, subcutaneous. The aim again of deep palpation is to check for deep masses. It is not to check for tenderness or rigidity, check for masses. Then you move to organs. Organ palpation should always start by palpating the liver. How to palpate the liver? Your hand should be in the right iliac fossa. All the palm of the hand should be resting on the abdomen of the patient, with your index finger parallel to the costal margin on the right side. So it is not this way. It is not this way. You always be in this position. The hand, all of it is resting with your index finger parallel to the costal margin of the patient. And then press strongly and ask patient to take a deep breath. Take a deep breath. Like this. Yeah. And then now you feel again. Now observe that I will not start to feel unless patient is taking deep breath, because this is the time when he is taking the deep breathing. This is the most suitable time to palpate the edge of the lever. So I'll do it again. No, stop. Now I press. Now you feel again. Okay. Take a deep breath. Now I can feel something. Take a deep breath. Notice that I feel by the index finger, not by the tips of the finger. And again, I will feel only when he is breathing deeply. Why is that? Because when he breathes deeply, when he breathes deeply, the liver descends down. And this is the time I can feel the edge. Not to feel when he is expiring, when he is in a phase of expiration, because during expiration the liver will go up again. So try to match your fingers with the respiratory movement of the patient. So press first, take a deep breath, now start to feel. Then move a little up. Press, take a deep breath, now start to feel. Press strongly, take a deep breath, now and you move your hand a little up like this. So you move your hand a little up. This is a very common mistake seen by students when they start doing like this, when you feel for a liver or spleen or any organ. This movement by itself may stimulate the abdominal muscle to contract, and hence you will not be able to feel any organs. So don't do this. Again, don't do this or this. Always rest your palm on the abdomen of the patient. Keep your index parallel to the costal margin. Move in this direction. Try to feel the edge of the liver only in deep inspiration. First apply pressure, then ask the patient to take a deep breath, and then feel. Apply pressure, nervous, deep breath, and then try to feel. A little movement like this. And then if we can feel the edge of the liver on the mid-clavicle line, I can trace the edge of the liver to see where it's going. And I can go medially to feel the left lobe of the liver. Same technique. Apply a little pressure for nervous, then try to feel in deep breath. Apply a little pressure, then feel during inspiration. Once you feel the left lobe, you may try to draw some mark to delineate the extension of the liver in this particular patient. I have to warn you that sometimes you'll be able to feel the right lobe of the liver alone, or you may be able to feel the left lobe of the liver alone. Other cases you may feel both right and left lobes. How to comment? Now in a patient like this, for example, if I can feel the edge of the liver at this line, which we draw now, we'll say that there is a palpable liver. The edge is palpable. This is the costal margin. The distance between the costal margin and the edge of the right lobe of the liver is about 2 centimeters in the mid-clavicle line. So I'll say that I can feel the right lobe of the liver 2 centimeters below the right costal margin in the mid-clavicular line. Again, we can feel the edge of the liver, right lobe, 2 centimeters below the right costal margin in the mid-clavicular line. And then you move and try to feel the left lobe. If I can feel the left lobe here at this line, Then I palpate for the xiphoid process cartilage. And I measure the distance between the xiphoid process to where I feel the left lobe. It is about 3 or 3.5 centimeters. Then I say that. And I can feel the edge of the left lobe of the liver 3.5 centimeters from the xiphoid process. So always comment on the right lobe and left lobe. Right lobe in relation to the right costal margin in the mid-clavicle line, left lobe in relation to the xiphoid cartilage in the midline exactly. I will be asked at this particular time to comment on the level. So you have to continue your palpation. Once you get the edge of the level, feel the surface and see if it is smooth or nodular. Smooth or nodular. And press a little on the level to get an idea about the consistency. Firm consistency is like the tip of the nose here. Soft is something like the abdomen or the cheeks. Hard, of course, like the skull or the wall. Most of patients with chronic liver disease due to liver fibrosis or liver cirrhosis, they have firm liver. Try to avoid the so-called hard liver unless really you feel it hard, because hard mass in general in the abdomen indicates most probably malignancy. So I am repeating that in almost all patients with liver cirrhosis, with palpable liver or liver fibrosis, the consistency is firm and surface smooth. If it is tender again or not, press on the liver like that and see. Look at the face of the patient. And keep your hand like that to see if the liver is pulsating. If it is pulsating, you feel pulsation under your fingers. Some people, they prefer to squeeze the edge of the liver a little up. And if there are pulsations, you notice that your fingers are moving down like this. So whatever the technique is, remember to comment on a pulsatile liver. So what is important now to comment on when you describe the liver? Remember whether the liver is palpable or not. And palpable what? Right lobe or left lobe or both. The edge. How many centimeters from the right costal margin? Don't forget to say right costal margin, mid-clavicle line. How many centimeters from the xiphoid in the midline or center exactly. Surface, whether it is smooth or nodular. Consistency, you have to apply a little pressure to get an idea about consistency. Soft, very difficult to feel. Firm, which is the most likely to be first in patients with liver cirrhosis fibrosis, and hard may indicate malignancy. And tenderness, you have to look at the face. And pulsations in the technique in the way which I just described. I have to say here that a palpable liver does not always mean enlarged liver, because the liver may be palpable but normal size. The liver may be palpable with hepatomegaly. The liver may be palpable even with small size, smaller than normal. So a palpable liver does not mean always enlarged liver. There is a difference between palpable and enlarged. Enlarged liver, we decide about it after measuring the so-called liver span only. Once we finish with palpation of the liver, then we start palpation of the spleen. Again, start from the right iliac fossa by your right hand. And same technique as we mentioned in the liver, we apply pressure first and then ask patient to take a deep breathing. Take a deep breath and then feel, and then move. Yeah, again, move, then try to feel it. Yes, until you feel the edge of the level. I have to say here that even if you know or you have in mind that the spleen is not crossing the midline, still you should start your palpation of the spleen from the right iliac fossa. Apply pressure. Ask a patient to take a deep breath and then move your finger when he is breathing in. Pressure, then move your finger. Pressure, then move your finger. Pressure, then move your finger. Pressure, move your finger during the inspiration until you feel the edge. Once you feel the edge of the spleen, then you start to feel and describe the spleen as an organ, like what we said in the liver. The edge, almost all the edges of spleen are sharp. Sometimes, not frequently, it may be rounded, but most of the time it is sharp edge. The surface of the spleen, smooth. Consistency, tender. Someone may ask, can you get tender spleen? Of course, you can get tender spleen in inflammatory conditions, in patients, for example, with splenic abscess, in patients with splenic infarction, sometimes in rapidly expanding tumors involving the spleen, like in hematological malignancies. The spleen may be painful and tender, so I have to be careful. So the edge, the consistency, the surface, and tenderness, if it is tender or not. But there is nothing called pulsatile spleen. So don't comment on pulsations here. Only the edge, the surface, consistency, whether it is firm or hard, and tenderness. And most important is the measurement, your measurement. Here we will measure from the tip of the spleen, which I can palpate, till the left costal margin. You draw a line like this in the direction of the splenic enlargement. Spleen, usually when it enlarges down and a little medially. Sometimes if it is usually enlarged, it may even cross the middle line like this. So we'll say that it is 4 centimeters from the left costal margin. Move your finger on the medial border of the spleen. Sometimes, if really spleen is enlarged, you may be able to feel for the splenic notch, and you can feel it by 1 or 2 fingers. This is an important sign. The splenic notch on the medial border is an important sign. Why? Because it helps to differentiate the splenic mass from kidney mass. Sometimes kidney mass is so big that it can be felt even anteriorly. And hence you may be asked how to differentiate. How to know for sure that this is a splenic mass and not a kidney mass. The answer should be, number 1, the anatomical position. This is in the left hypochondrium. Only. It's not filling the loin, not filling the renal angle. Number 2, the direction of enlargement. Direction of enlargement, infero-medially. Infero-medially. What else? The fact that you cannot put your hand between this mass, which is a spleen, and the costal margin. In other words, you cannot reach the upper border of the spleen. While kidney, if this is a kidney mass, you can reach the upper border. You can put your hand between the kidney mass and the costal margin easily. The presence of a notch, as I said, helps to differentiate splenic mass from kidney mass. The kidney mass does not have a notch, which is on the anterior border, as I said before. So, the anatomical position, direction of growth or enlargement, the presence of notch, whether you can or you cannot put your hand between the mass and the costal margin. Ballotment. You may try to do ballotment. Kidney is a ballotable structure. You can get a so-called posterior ballotment. You push the mass, which is the kidney, by the upper hand and you receive the impulse in the lower hand. It's called posterior ballotment. This is not the case in the spleen. And finally, by percussion. A splenic mass is dull because it is under the abdominal muscles. It is intraperitoneal structure and intraperitoneal growth, while kidney mass is resonant on percussion, not because the kidney itself is resonant, but because it is overlapped by bowel, by the colon, and the colon, as we know, is full of gases, and so that resonance is the resonance of the colon, which is overlying the kidney mass. So to differentiate between splenic mass and kidney mass, you have to do the techniques which I mentioned, and it is very important to differentiate between kidney and splenic mass in any patient. Once you finish palpation of the liver and spleen, try for palpation of the kidney itself. One hand, which is the right hand, should be in the renal angle of the patient. Let us do it on the other side. One hand in the renal angle. The other hand in the front like this. Apply a little pressure. Ask patient to take a deep breath. If there is a kidney mass, I'll be able to feel some cystic swelling moving between these two hands, up and down, with the movement of respiration, because respiration also affects the movement of the kidney. It has its effect on the kidney movements. And you do the same on the right. Start by the right and on the left. If you get a kidney mass, do the ballotment in the same technique which I explained before. Important also to try to feel for the upper border of the urinary bladder. Some people, especially those who are in pre-coma, coma, may get retention of urine. They are unable to pass, and hence the urinary bladder will start to enlarge until you can feel it, even up to the umbilicus. Missing a urinary bladder distension may be very bad for a physician, because it's back pressure on the kidneys, and if the patient is awake, it is very painful. And I have seen many times diagnosed as abdominal tumors and some other funny diagnoses, whether if you pass a catheter and drain the urine, the mass disappears instantaneously. So, organ palpation, liver, spleen, kidneys, urinary bladder. And once you finish these 4 organs, you have done a very good job. The most important is to do the technique in the proper way. Now suppose that the patient is guarding his abdomen. I cannot feel organs because his abdominal muscles are tense. Then you have to ask the patient to flex his legs like this. And this helps to relax the abdominal muscles a little and give you more chance to palpate for the internal organs easily. Now suppose that the spleen is not felt in this position and by this technique, and still you are asked to check for the splenomegaly by palpation. What is your next step? Next step is to bring the patient on the right lateral position. So you have to come from here, come to this side, please, like that. Right lateral position. Please observe that position. This hand should be here, and this leg should be flexed like that. This is the left leg, while the right one is extended, like that. So the position is clear. The upper leg now, this is the left, it's flexed. The lower one is extended. Patient arm is hanging on the bed like that, or holding anything, giving you chance, giving you space. And then start feeling for the tip of spleen by the tips of your fingers. So a little pressure also may help from the back, and ask patient to take a deep breath again. Take a deep breath and start feeling. Again, and now I feel the edge of the spleen. This is done, the technique, this particular technique is done whenever I find difficulty in palpating a spleen in the supine position. Of course, we will not do it if I can feel the spleen in the supine position. So, again, right lateral position with the left leg flexed, the right leg extended, the hand or the arm is hanging, the abdomen is relaxed. This position helps to relax also the abdomen and brings the spleen near my fingers. A little push from the back and palpate by the tips of your fingers until you get the edge of the spleen. Ask him to take a deep breath in and out as we said before. So I repeat that we don't do the right lateral position for palpating spleen unless I am unable to feel a spleen in the supine position. Once we finish with organ palpation, the next step is percussion. Percussion, remember, we percuss the liver, percuss spleen, and percuss any other organs you can palpate in the abdomen, and don't forget to percuss for the renal bladder. Percussion of the liver. Of course, liver has upper border and lower border. Whatever you like to start by the lower border or the upper border is up to you. Let us start by percussion of the upper border. Feel for the sternal angle. Again, the space, intercostal space here is the second intercostal space on the right side. And then apply your fingers on the chest of the patient tightly. Don't let air between the fingers and the chest. Your middle finger here in the left hand should be in the intercostal space, not on the rib. Start by the second intercostal space and then percuss with the middle finger on the middle finger. Use the wrist only, don't use the elbow, don't use the shoulder. And then give the percussion like that. This is resonant, move one space. Resonant, resonant. This is done. Once you get dullness in the mid-clavicle line, as you notice, ask the patient to take a deep breath and hold it. Now I want to do that like this. Hold. Then percuss again. Now it is resonant. خلاص. Then stop. So what does it mean? It means that there is dullness which changes to resonance if the patient is asked to take a deep breath. If the patient is asked, what do you call it? We call it tidal percussion. And it means that the dullness, which you can appreciate, is supradiaphragmatic. It is due to the upper border of the liver. We put some mark here, and then we go and percuss the lower border. Again, make sure that you are in the mid-clavicle line. Tight pressure on the abdomen. No air between your finger and abdomen patient. Relax. Open your fingers like this. Percuss by middle finger. Use the wrist. Don't use elbow. Don't use shoulder. And percuss. Now let us say that when we the edge of the liver, percuss parallel to the edge of the liver. Exactly like what we said during palpation. So, resonant, 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 dull. So we get dullness here. Measure, and this is called liver span. So the liver span is the distance between the upper border and lower border by percussion. The normal liver span is something between 8 to 12. That's 10 plus minus 2. If the liver is more than that, let's say more than 12, then and only then you are allowed to say hepatomegaly or enlargement of the liver. So liver span will help us to detect whether the liver is enlarged or not. If it is more than 12 centimeters, then it is enlarged. This is hepatomegaly. Then you may percuss for the left lobe of the liver also. and make sure that this is really dull, because it's supposed to be dull. Then you percuss in the midline, same technique, until you get dullness. Then you are sure that this was the left lobe of the liver, as previously mentioned during palpation. But the liver span indicates the distance between the upper border and lower border of the right lobe in the mid-clavicular line. Next, you have to percuss for spleen. As I said, in palpation, you start from the right iliac fossa. The same percussion starts from the right iliac fossa. Apply pressure. Keep your fingers in tight contact with the abdominal wall of the patient. Use the same techniques for percussion. But now you have to draw for yourself a line, certain line, which you should percuss along this line. Don't keep percussing in this way or like that, curved way. A line which your eye will draw from the right iliac fossa to where you palpated the spleen before, or towards the left costal margin in the area which is called left hypochondrium. So you percuss in this direction, that one. Resonant, 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 resonant. Notice that I am moving only my wrist, no elbow. Resonant, resonant, a little dull. So you say that the spleen is dull on the area which I palpated before, same place. Don't stop here. You have to continue percussing spleen until you reach the costal margin and even above it. Like that. Again. Resonant, 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 dull, dull. Now go on until you percuss the last 2 or 3 intercostal spaces. Dull, dull. Why is that? Because, as I said, the spleen extends below the costal margin up. And that triangle, which I'm going to draw now, it is a triangle which extends from the costal, from the xiphoid cartilage along the costal margin here. This is the costal margin of the patient, and anterior axillary line, anterior axillary line, and lower border of the 7th rib. So as you notice, it is a triangle with its apex as a xiphoid cartilage, with its base as the anterior axillary line, and then costal margin below, left side of course, lower border of the 7th rib on the left side above. This triangle, we call it Traub's area. T-R-A-U-B as in boy, S area. Traub's area is supposed to be overlying the fundus of the stomach. Underneath it, there is the fundus of the stomach, which is always full of gas. So it's supposed to be not only resonant, but tympanic. Tympanic is some form of hyperresonance. But if it is dull, it indicates a pathology, certain pathology. So I'm repeating. You'll be asked about what's Traub's area. Traub's area is a triangular area in the left side of the chest of the patient, lower part, lower zone, bounded by the xiphoid cartilage medially, anterior axillary line laterally, costal margin, left costal margin lower, and the lower border of the 7th rib as an upper limb here. What is normal? Normal, it should be tympanic, hyperresonant. Why? Because it is overlying the fundus of the stomach, which is always full of gas. What is the abnormality? Abnormality is dullness. This is abnormal. What is the differential diagnosis of dullness in Traub's area? Just remember what are the structures which are present here. There may be some pathology in the chest itself. So this is the chest. So any problem in the pleura, like pleural thickening, pleural tumors, pleural cavity accumulation of something, fluids, blood, will give dullness. Any pathology in the lung itself on the left side, like collapse, fibrosis, mass, etc., will give dullness, may give dullness in TROPS area. Or abdominal disease, like what I said just now, splenomegaly, because it is extending below the left costal margin, may give dullness in TROPS area. Tumors of the fundus of the stomach may give dullness. Marked enlargement of the left lobe of the liver, if it extends till it involves TROPS area, again may give dullness. So, bone tumors, pleural pathology, hydrothorax or pneumothorax, lung disease in the same area here, atelectasis, fibrosis, masses, etc., enlargement of left lobe of the liver, and the enlargement of the spleen or splenomegaly. Many times spleen may give rise to dullness in TROPS area, but you cannot feel it. If it is just all is small, it needs some expertise to palpate such a spleen. But dullness in TROPS area may help. I mean, if you are in doubt whether the spleen is palpable or not, I can feel something here, but I am not sure whether this spleen or this is the rectus muscle of the patient or whatever. Percuss TROPS area. If TROPS area is tympanic and hyperresonance, this means that what you feel here is probably not the spleen, because if it is the spleen, that TROPS area should be, most of the cases, almost most of all cases are supposed to be dull. So dullness in TROPS area is a very important sign when you perform abdominal examination. So we finish percussion of the liver for liver span, percussion of spleen in the direction of splenic cross, and don't stop at the costal margin, go and percuss over TROPS area. Remember boundaries and differential diagnosis of dullness in the TROPS area. If you feel that the bladder is full, then you have to percuss bladder from above down in the middle line, like this. It is resonant. If the bladder is really distended, of course you will get dullness over the urinary bladder. What is left now by percussion is the so-called shifting dullness. Shifting dullness is a percussion technique we are using to look for ascites. In summary, how to perform shifting dullness. First of all, you have to understand this fact that when there is fluid accumulation or collection in the peritoneal cavity, it will have a level. This level may be low, may be high, but it will be equal here and there, unless of course some loculated solution or encysted fluid, etc. This level most of the time is in the flanks. So when I discuss, my aim is to see where is this level, fluid level. Of course, the fluid is dull, gas is resonant. Number one, I should detect where is the most resonant area in the middle line. The most resonant in the middle line. So percuss from above down. This is not resonant actually. This is resonant. This is resonant. This is the best. So notice the direction of percussion. From above down. Once I decide about the most resonant area, now I'll change the direction of percussion. Because as a rule in medicine, when you percuss parallel to the border you want to detect. And that's why when we percuss for the liver, we percuss in this direction. Because our fingers should be parallel to the edge of the liver. The same, when we percuss spleen, we percuss in that direction. Because our fingers should be parallel to the costal margin on the left side. The same if you percuss for ascites, and I know that the fluid level taking that shape like this. So my fingers should percuss parallel to the upper border of the fluid, whether on the right or the left. Shall I go right or left? It depends. Suppose the patient has a marked hepatomegaly. Till here, I cannot percuss the right. Then I move to the left. And vice versa. If the spleen is markedly enlarged, usually enlarged, then I should percuss on the right side. If I cannot feel liver or spleen, no masses, I percuss right or left, whatever. So again, the middle line, percuss until you get most resonant area, then change direction of percussion. Now put your fingers parallel to the fluid, assumed fluid level. And make sure that when you percuss, you be away from the palpable organs, so a little below that splenic edge, splenic border. Okay? So I will not percuss here because there will be dullness. Middle line, maximum resonance, change, parallel to the border, upper border of the fluid, and then the same rules. Your hand should be in tight contact with the abdomen of the patient, no air. Don't percuss with one finger like this. Don't percuss on the four fingers like what we see done by some of the colleagues. Percuss only middle finger on the middle finger. And now start to move. Resonant, 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 resonant. Well, there is some dullness here. Do it again. Resonant, 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 resonant. Yeah. This area is dull. Next step, fix your finger and ask patient to come to this side. Again, the right lateral. Fix your finger. Don't move your fingers. Always keep your fingers, the area of dullness. And wait for some time. You'll be asked why you wait. Waiting for what? Waiting for that fluid to descend down and replaced by the bowel, which will float up. So what will be under your fingers now? The colon or the intestine, whatever. After giving chance for fluid to go down and the bowel to float up, then repeat percussion again, same area. We notice the change now becoming resonant. Don't stop here, because if you stop here, this will be shifting resonance. I am not checking for shifting resonance, I am checking for shifting dullness. So there is resonance here. Continue and percuss down. Move down. Move down. Move down. Move down. Now it's becoming dull. This area was resonant before around the umbilicus. Now why it is dull? It's dull because the fluid descended down while the intestine floats up. Now and only now, when I detected the dullness which was in the flanks before, I detected around the umbilicus in the area which was resonant before, now and only now I can call it shifting dullness. The dullness was here, shifted to there. Shifting dullness in a patient with a chronic liver disease indicates ascites. If ascites is too much, I mean abdomen is marked, still with fluid, sometimes you will be asked for another technique to detect fluid in the abdomen, or so-called ascites. Then you say yes, there is another technique which is called the transmitted thrill or fluid thrill. What is the fluid thrill? You apply, ask patient to get his hands and do like this. Yeah, like that, and apply pressure. If you don't ask him to apply pressure, then you didn't do the technique in the proper way. Why you ask to apply pressure here? To interrupt the wave from being transferred through the abdominal wall. I interrupt it by hand, the hand of the patient or any assistance, and then feel on the left flank and give some pressure or hit on the right side by 2 or 3, or even by all these fingers like that. Like that. Some people, they like to do this, but I find it not convenient to patient because this is painful. You can try it on yourself. Then do like that. Now, if I can feel in that position, if I can feel by my left hand the fluid thread, the transmitted thread through the abdomen to the other side, it indicates the presence of significant amount of fluids. I am repeating that the hand of the patient should be in midline or the hand of the assistant this way and should apply some pressure. Why you apply pressure? To avoid transmitting of the wave through the abdominal wall, which will give a false impression that there is the so-called transmitted or fluid thread. Apply pressure in the middle line, left hand on the left flank, then you apply the technique on the right side, and if there is fluid, you can appreciate it by that one. Which is more sensitive? Is it the shifting dullness or transmitted thread? Of course, the shifting dullness is more sensitive. More sensitive. Fluid thread will not be positive unless there is really accumulation of very big amount of fluid in the abdomen patient, liters. Some people may say even more than 2 to 3 liters or above. While shifting dullness may be positive in as low as 500 ml only of fluid in the abdomen of the patient. That's why we consider it as more sensitive technique. So, percussion of the liver, percussion of spleen, continue costal margin, percuss trops area, percuss any other mass you can get, and describe. Don't forget to get the liver span in centimeters. Percussion for the bladder, and then percuss for ascites, shifting dullness, and fluid or transmitted thread. What about this patient? In this patient, we get palpable liver, palpable spleen, and pulsive shifting dullness. What is the liver span in this patient? You measure it. It is more than 12 centimeters. So now you can say that my diagnosis, my impression till now, that there is hepatosplenomegaly. Why hepatomegaly? Hepatomegaly because it is more than 12 centimeters liver span. Why splenomegaly? Because the spleen is palpable. There is no splenic span. Just the palpable spleen is considered to be enlarged because we know that in order to feel the spleen, just palpable spleen, you need a spleen to be enlarged 3 times at least of its original size. And then percuss for ascites in the way which I mentioned. Now what is left here in the abdomen is auscultation, and there is not much to be said about auscultation because there are 1, 2, 3, 4 points and that's it. Therefore, put a stethoscope on the iliac fossa, right or left. I prefer the right side, and keep for some time and document on the intestinal sound whether they are exaggerated or not. Keep a stethoscope for some time, couple of minutes, to appreciate intestinal sound. You don't remove stethoscope quickly. Keep it for few minutes. And then put a stethoscope on the liver. Why is that? Because if I can appreciate or if I can hear bruit, B-R-U-I-T, this is not a good sign. Hepatic bruit may indicate a hepatocellular carcinoma. Don't put it only in one area. Go through all the liver and be patient. Be sure that the room is quiet and concentrate. This is arterial bruit. It comes with the pulse. This indicates hepatocellular carcinoma, most of the cases. The so-called venous hum, sometimes may be appreciated also, is not of the same importance as the hepatic bruit. Don't forget to listen for hepatic bruit even on the left lobe of the liver. because the tumor of the liver may be in the left lobe. And because we know that hepatocellular carcinoma may complicate chronic liver disease like liver cirrhosis or whatever. Then, listen on the spleen. For what? For friction rub. Friction rub is a superficial leathery sound, which is heard best by the diaphragm. It's a friction rub, indicative of what? May indicate the presence of a splenic infarction, perisplenitis, splenic abscess, rapidly growing spleen by invasive and infiltrating tumor. So, sign sound, hepatic biliary and venous hum, splenic rub in the cases which I just mentioned. What else? By auscultation, about 1-2 centimeters lateral to the umbilicus, apply a little pressure on both sides, this side and that side, and listen for the so-called renal artery bruit. These are again systolic bruit that they come with the upstroke of the pulse. If they are present here or there or both sides, they may indicate the so-called renal artery stenosis, which may be unilateral or bilateral, unilateral or bilateral. Finishing that, you have finished the auscultation of the abdomen. Before we stop, I have to say that sometimes some people may ask you a question. Suppose that you cannot detect ascites by fluid Israel or by shifting dullness, but still you want to rule out the collection of small amount of fluid in them. What to do? Then the answer is put the patient in the elbow knee position. Okay? It's called elbow knee position. And then discuss around the umbilicus. Only around the umbilicus. Around the umbilicus, which was resonant before, if you remember. Now we apply pressure. You do the percussion in the same way which I mentioned before, and percuss. Now we notice it is done. Like that. Only that. Then, خلاص. Tell the patient from the other side. You remember that this area was resonant before. So if it was resonant in a supine position, if it was resonant around the in a supine position, while in the elbow knee position it turns to be dull, this means that there is accumulation or collection of a small amount of fluid, which cannot be detected by shifting dullness technique. Finishing that, you have finished the abdominal examination, and then of course they will start discussing investigation and management, etc. Don't forget to say at the end, since this is an abdominal case, that my diagnosis is hepatosplenomegaly with ascites. Hepatosplenomegaly with ascites, because post-shifting dullness, and because this is a chronic liver disease, you tell the examiner, I would like to examine the genitalia of the patient and to do a PR examination. Why is that? Genitalia, because we know that in a patient with advanced chronic liver disease, accumulation of estrogen may lead to testicular atrophy. And so you have to look for the size of the testicles. Many people, they don't know even the normal size of the testicles. The normal size of each testicle is 3 to 5 cm. 3 to 5 centimeters. And what else? Do a PR examination. Why? I want to look for hemorrhoids, piles. Because portal hypertension may lead to esophageal varices and also hemorrhoids. And get your finger out and look at it and look for blood, whether it is fresh blood or dark blood. Fresh blood is a bleeding perirectum, and dark blood is the so-called melena. So of course you should not do it in every patient. You ask permission of the patient. Tell the patient, please, I want to examine your genitalia. Do you agree? And then I want to do a PR examination. If the patient accepts, well and good, go and do it always with gloves. If the patient doesn't agree, then you have to stop here. Don't try to force your patient, because this may be quite embarrassing. Finally, you may be asked, what are the signs of portal hypertension in a particular patient like this? So I'll say, well, I have splenomegaly, there is ascites, and by PR examination, if you have done it, there was hemorrhoids, piles, or some bleeding per rectum. What to do to prove portal hypertension, I mean more by investigations? Of course, I'd like to do upper GI endoscopy to look for esophageal varices. Yeah, so it should be easy. And by that you have completed the abdominal examination or the examination of the abdominal system, and it will be the time for discussion of investigation and treatment. Thank you very much.